this is the first opportunity that actually I've stood up before all of you at Melanoma Patients Australia to thank you for giving me an award last year. And it's actually means a lot to us, that it's very special on our CVs if we can show some evidence that actually the work we do is supported by patients and by consumers. So thank you very much to all the Melanoma Patients Australia family. We've just heard from Jonathan Seebon and also from David that, look, this is a special time, for this disease. We're making real inroads. Just this morning, I was privileged to introduce at the conference that's running a chap called Jim Allison from Texas, who's in town for the big Immunology Congress. He's the guy who came up with this whole idea of all those checkpoints that Jonathan spoke about. And I took a liberty, and a liberty I took is on behalf of all of you to thank him for what he's done for patients. And I actually got a bit emotional this morning. I'm just getting a bit emotional again because, it really is an incredible impact that these treatments are now having. Not everyone, and we've got to do better, which is why we need to do more clinical trials. So that's the topic of my talk today. So I want to just share with you some ideas, sort of thinking about what I would do if I was a melanoma patient, given the knowledge that I have about how we do research and how we make benefits and steps forward in getting better outcomes for the disease. So I'm going to try as best I can to get away from the technical stuff and answer this question: how do I get onto a really good clinical trial? Now, there's lots of progress in melanoma and lots of hype. This is actually excerpts from my favourite magazine that I love reading when I've finished my day's work, The Economist magazine, and they've had big articles on immune therapies for cancer and also including melanoma and targeted therapies for melanoma, as shown there on the right. So there's been, a lot of hype, and as I'll get to in one of my slides, be careful about what's in the media, because one of my very early experiences, actually, I remember talking to Jonathan Seebon about this example I'm about to give you, a very unpleasant experience, was when basically you could almost describe this individual as a snake oil salesman, got front page headlines on the Herald Sun about a completely unproven treatment. And we were talking to this individual and looking at the possibilities of doing a trial to actually get some evidence, but he wanted to go to the Herald Sun and put up his share price of his company, which did happen as a result of the publicity. So just because it's in the media doesn't mean that it's any good. Even The Economist, you've got to be careful, despite the fact it's a very well-respected magazine. They certainly don't like Donald Trump at The Economist, I might add. Okay, so what is a clinical trial? So I actually got to define this because it's actually a scientific process that we use to test interventions, I've underlined that, aimed to improve outcomes for patients or to test a new diagnostic procedure. Now, why have I underlined interventions? So really when we talk about clinical trials, we talk about a scientific process that does something to you as a patient, as opposed to just get you to fill out a questionnaire, right? So when we talk about clinical trials, we're talking about interventions. And because something is being done to you, you can obviously have the benefits of a great outcome. And of course, clinical trials, you all know, is how we test new and exciting things like The Economist magazine spoke about. So it's absolutely critical. So it's about interventions. There's other types of clinical research though. And, I would encourage all of you to be involved in as much research as you can to gain knowledge. We measure outcomes. We need your consent to do that. We measure burden of disease across our society. We collect tissue to do all those wonderful sort of studies that Jonathan referred to understand a disease, and you giving permission for your tissue to be used for research is pretty important. And we do clinical research on understanding your experiences of cancer and try to learn for other patients there. So there's lots of clinical research. I've been involved in 2 areas of clinical research. One, I donated some tissue, and the other, I went on a randomised clinical trial once when I had a blood clot about a very new drug. So I'm very committed to it as a patient as well. And hopefully at the end of my presentation, I can convince you that you should be as well. All right, so let's get into the actual clinical trials and what they are. Now, how do we develop a new treatment for cancer? So there has to be some scientific discovery happening somewhere, like Jim Allison discovered that molecule, one of those brakes called CTLA-4 that Yervoy turns off, that Jonathan spoke about, and he spoke here at the conference this morning. You then do some experiments in the lab test tubes, and then the experiment Jim shared with us this morning, where he knew he was onto something, was a mouse experiment. His young scientists in his group brought him this melanoma tumour growing in a mouse that when they treated with the mouse version of Yervoy, the tumours went away completely. Jim just didn't believe it. It was too good. And so he was actually telling me this morning, he made the young scientist do the experiment again, and Jim went into the lab himself, into the animal facility, and measured the tumours himself because he just didn't believe it was so good. So you do all those experiments, and because of that, that could then kick off the idea of turning off the CTLA-4 in a clinical trial. Now, the traditional way we do clinical trials is we do what's called phase 1, and that's really working out what's the dose of the new treatment we should use. How often should you give it? Is it safe? Then you do a phase 2 trial and working out how does it work. And then you do phase 3, and I'll get to this, the concept of randomised trials, where you compare one thing against the other. So that's a traditional way. Now, pleasingly, that's changing. Where better has it changed than the drug Keytruda? So Keytruda, people say it was just a phase 1 trial and all the phase 2 and 3 were got rid of. It's not quite true. It was the world's biggest ever cancer phase 1 trial with about 12 or 1,300 patients on it. Phase 1 trials used to be less than 100 patients. But in fact, there was that does it work bit was really more like a phase 1 and 2 combined. But nonetheless, that's important because it meant that, as we'll get to the process of a clinical trial, that there was one set of paperwork submitted to multiple hospitals around the world, and that addressed the dose. How often do you give the treatment? Is it safe and does it work? And all that body of knowledge led to Keytruda becoming available. And we have to be thankful that we were actually one of the first countries in the world to get access to Keytruda. And I'm not going to talk to you about the PBS and other things like that. That can perhaps come up in discussion. But we were fairly lucky there. That's unusual. Australia is not usually one of the first, but we were lucky with Keytruda, in part because we've heard about melanoma being Australia's disease. So if all that goes well, you bring a new treatment into clinical practice. One of the problems has been the success rate of even when you get into phase 1 in cancer has only been about 10 to 15% of a new treatment coming forward. And then there's many things that look promising in the lab side of things that never make it. And that's in part one of the reasons why these treatments are so expensive, because that takes time. So typically we used to say it takes almost 20 years, this whole process, but now with clever interventions that can be 5 to 10 years from the initial discovery to becoming a new treatment. But it doesn't happen overnight. So when you hear something on the media about new target for cancer, it's not going to be available within a year or two. Now, really important, should I go on a trial? Well, am I being just a guinea pig? Well, not really, because there's been some analysis done here of almost 8,000 patients with cancer that went on a trial versus those that didn't actually live significantly longer. Okay, so that's very interesting. But the way we interpret this is that you don't do worse from going on a trial. You're not a guinea pig that's getting nasty things done to you. In fact, statistically, if you go on a trial, you're probably going to do better. So why would trial participants do better? And this gets to what a clinical trial is. There is a rigorous protocol that's written by experts like Jonathan and David and from around the world that say this is the best way of treating this condition, and there's a strict protocol to follow. Sometimes you get frustrated when you're a patient on that because you'd like to have a deviation from the protocol, and the researchers say, oh no, we can't do that. But following the protocol is how we get good evidence how to use new treatments, and actually it probably contributes to why trial participants do better, because you're getting state-of-the-art care. You get great care by an expert team. So when my patients are not on a clinical trial, they have great nurses and myself, but when you're on a clinical trial, they have all those same staff plus all the trial staff to look after you, so you get really great care. Now, there is a scientific caveat, because in science you always question, you're always sceptical, you always keep questioning the things you observe. So why might trial participants do better? It could be that fitter people go on to trials than don't go on to trials, so that's possible, and that may be a difference, but we can certainly conclude that you're not a guinea pig, you don't do worse if you go on to a clinical trial. Now, what about types of clinical trials? So I talked about phase 1, 2 and 3. We're tending to think now about early phase and late phase. So early phase is sort of rolling that phase 1 and 2 together. Is it safe? Does it work? What dose should we give, etc. So that's early phase. Late phase tends to be, is it better than the existing treatment? Okay, and that's what a late phase trial is. Trials can be single arm, and I'll get to the advantages of that shortly. So that means you know exactly what you're going to get, versus multiple arms where you get this toss of a coin thing in the randomisation. We're actually trying to innovate now, and instead of doing treatment A versus treatment B, you actually do treatment A versus B, C, D, E, F, where the control, and I'll get to controls because some patients don't like going on controls. If you have one control and then everything else is new and promising, that's a much more efficient way of doing trials. So we're trying to get that sort of thing up, and we're talking to Vice President Joe Biden about the Moonshots program in the US that he's started to start doing worldwide trials like that, which would be much more efficient. All right, now control arms. So this is the touchy one. And I'm going to get to a really tough example in a moment. But why would we do a randomised trial? Why would we say, sorry, only half of you or some other proportion are going to get the new treatment, and half or some other proportion are going to get the old one? So it's about certainty. It's the design that provides absolute certainty that the treatment is better, and that's what many governments need to pay for treatments especially, but also even just to say you can use them because it's the most robust way of doing it. And that's because, you just look around the room here, I mean, we're all different, we're all individuals, and you need significant numbers of people, and you need to control for all the differences between us. So, and what trials do is they control for things we don't know about. So I'll give you an example. A hypothetical example. If we think about us in this room as Australians, and then we think about our friends and relatives that live in Ireland, okay, what are the differences? Well, they have nowhere near as much sun intensity as what we do, the UV. And that can change your melanomas potentially. We've just heard today at the conference about there's a lot of more mutations in the genes if you get a lot of sun, for example. So Australian melanomas have more mutations than melanomas of people in Ireland. If you think about, our demographic, the classic person in Ireland is fair, high rate of people with red hair, okay, higher than there is in Australia. So what if the number of mutations in your melanoma made a difference to whether the treatment was going to work, or whether you had red hair or not made a difference, just hypothetically? If you then compared one study in Ireland to one study in Australia, you'd get the wrong answer because the melanomas are different. That's why we randomise. We take Ireland and Australia together and we randomise, and it just balances out all those differences between Australians and the Irish. Now, I'm going to give you the tough example. So this is something I lived through because I was co-principal investigator of the first BRAF inhibitor trial with Zelboraf. So it was exciting. We were seeing patients' tumours just melt away with Zelboraf. And the New York Times, one of their journalists, who was a Pulitzer Prize winner, ran a whole series of articles, including front-page articles in the New York Times about Zelboraf. But when we came to have to do the trial to prove that it was better than the previous treatment, it was a trial comparing chemotherapy to Zelboraf. And the New York Times also ran a story that down here there were two cousins that both went on the Zelboraf trial. One got chemo. He's sitting in hospital, not looking so well, where his other cousin got Zelboraf and he was doing really well. And they ran this article around, is this fair to do randomised trial with something that obviously worked? So there were lots of articles. There were articles written in the New England Journal of Medicine, which is the world's premier medical journal, saying, is this is a dilemma? Should we be doing sort of the trials differently? And I had to be part of the group to defend and work out what we did about this trial as the evidence started coming through that Zelboraf actually did look pretty good. And so what we did was we changed the statistical design so we would finish it quicker, but we didn't abandon it. Some people wanted us to abandon it, but because we went through with it, really that rapidly established worldwide that Zelboraf is a treatment that was going to work. Also then you can do trials slightly different way that gets away from this problem of not getting the good treatment, and that is the thing called crossover design. So when Taflunar or dabrafenib, which some people in the room probably have taken, came along as a second BRAF inhibitor. We'd learnt already that a BRAF inhibitor would work from the first trial. So the trial was chemotherapy compared to dabrafenib, but if your tumours grew on the chemotherapy, you would then get the dabrafenib. So it's called crossover. So that way, virtually all patients on the trial got the new treatment, and that's increasingly now a design that helps us deal with things we think are pretty good. We're not 100% certain. We still need to do the trial, but it allows everyone to get access. So that's something you can ask your oncologist. Is there a crossover design? Can I get the treatment if I'm on the traditional older treatment? Now, this is, I think, a critical question. How do I know if the trial is any good? So how do I know if I've been offered a trial, it's any good? Okay, so this is a paraphrasing of what I tell the young scientists, how you pick, whether you're onto a winner. So I'm showing you here the summary slide that I showed to young scientists. Okay, I've just changed the wording a little bit. So I say to the young scientists, you need a strong hypothesis. You need to know really what the details are of the cancer and what makes it grow, how it behaves, and if you really understand that and you think you're onto a new target or something that's going to change all of that, that's very helpful. The lab data has to be really clear that it's going to work, a bit like what Jim Allison saw, and he had to go and measure the tumours himself because he just didn't believe it because it was so good. That was clear and robust, and have a look now what's happened with Keytruda and Yervoy, etc. We have to have new drug treatments that you get good levels in the body. Some chemicals or substances you'll put in the body and the body gets rid of them in minutes and they'll never do anything to a cancer. And this is something that you guys can do, what are the early clinical results? Are patients responding? You can ask your doctor that. And these are all the things that I say is the recipe for success in finding a new cancer treatment. Now, you can go on a thing called clinicaltrials.gov, which is an American site, and it lists all the centres around the world that are doing the trial. So one of the other distinguished visitors we had here is from Memorial Sloan Kettering in New York Hospital, one of the world's biggest cancer hospitals. If they're doing the trial, that's an endorsement that it's probably a pretty good trial. Or if the Olivia Newton-John Cancer and Wellness Centre or Peter Mac or other renowned places doing the trial, that's a good sign. Now, the final point here is an important one. You really need to get under the care of experts, because Jonathan and I and David and our colleagues, we know the results before they're out in the general public and are published. Now, a lot of them are confidential, and we won't sort of sit down and disclose all this confidential stuff to every single patient, but we have the knowledge and we've seen the early results, and so we will advise towards a trial. So basically what I'm saying here is that there's a lot of advantages in having, if you want to get onto a clinical trial, being under the care of someone who's, you know, a real expert and up to date with what's happening. All right, now I'm just going to finish up, Hayley, with some frequently asked questions, and there's one that I should have put on, so I'm going to mention it first, that occurred to me I should have put on, and that is, I'm told I'm not eligible for the trial. Can you reverse that? Can I still get on? And this is a really tough one. So unfortunately, there's really rigorous rules now by the regulators that, so this is the government agencies that set the legal framework we're allowed to do trials. We can't vary eligibility. It's an absolute no-no. We have all these audits on eligibility. They pay a lot of attention to it. So unfortunately, you know, it's not something that can be waived, but then you can ask your oncologist, well, is there another trial with different eligibility that I may be able to get on? One question is, well, should I go on a trial if I'm going to get the control? So let's just go back to that chemotherapy in Zelboraf. So in fact, 14% of people that went on to that trial that got the chemo never had a dose of chemo because they didn't really want it. Now, you shouldn't really go into a trial if you're not happy to have whatever the coin tosses up. You should think about other means of access. You should always ask about what are the side effects, because that's in the information forms you get given about a trial, but they are important and they do vary. Sometimes they're mild, sometimes they can be quite severe. Now, often question is, can I get on the trial in my local hospital so I don't have to, get a park at $18 a day in this building? And can I just get the trial in my local hospital where the parking's only $5 and I don't have to drive so far? Now, unfortunately, a part of the trials process is that the centre that's doing the trial has to be accredited in many different details, by the government agencies and the sponsor of the trial. The sponsor of the trial can be the Olivia Newton-John Cancer Centre, or it can be a pharmaceutical company. So unfortunately, the trial can only be performed at sites that are accredited for that trial. Now, what about, are there better trials overseas? Now, pleasingly in melanoma, there's nearly always the very best trials running in Australia. We get them early. So I have, over the years, I think only sent 3 people overseas for trials in all my clinical experience for melanoma. I have for other diseases where it was clearly a breakthrough but just wasn't available in Australia. But in melanoma, it's very unusual not to have the very best trial available. So I might finish up there, and I might just on the trial overseas question. So I'm often asked about one of the patients that I've cared for. It's very much been in the public domain, which is Ron Walker. And Ron Walker is a wealthy businessman. Did he get on a trial because he was a wealthy businessman and he was Ron Walker? And I emphatically say no. It was always first in, first served on any clinical trial. That's a strong ethical principle we follow. Yes, if you're Ron Walker, it's easy to fly to Los Angeles to go on the trial. But there were other Americans that could have, that were lining up as well. There was him, he was just there at the right time. There was a spot available, and so he got on. It wasn't because he was Ron Walker, it was simply because there happened to be a spot. He did have the means, though, to be able to jump on a plane which of course many people would not have the resources to be able to do that. So yeah, we don't select VIPs for clinical trials. Strong ethical principle. I'll leave it there. Thanks, Hayley.